So I'll begin with an introduction for our three amazing speakers. Dr. Camilla Buchanan is a 1966 graduate of William & Mary and completed her medical schooling at Virginia Commonwealth University. Camilla had an active OBGYN practice in Williamsburg for over 30 years. As an adjunct lecturer at William & Mary, she teaches global and public health and travels frequently to Kenya with MAO Kenya to promote women and children's health at the community level. Dr. Iyabo Obasanjo is an assistant professor in the Department of Kinesiology and Health Sciences. She received a Doctor of Veterinary Medicine from the University of Ibadan, Nigeria in 1988, and a Master's in Preventive Veterinary Medicine from the University of California, Davis. At William & Mary, Iyabo currently teaches courses that relate to public health, global health, and health policy. Our third presenter, Dr. Ashley Everhart Queen, is a senior lecturer of kinesiology and health sciences. She has an educational background in biology from the University of North Carolina at Charlotte. Ashley is also a May 2020 graduate of the Higher Education Administration doctoral program at the William & Mary School of Education. At William & Mary, Ashley currently teaches courses that relate to human physiology and also serves as a pre-health advisor to pre-nursing and pre-physician assistant students. Without further ado, we're going to get started with Ashley's presentation. Ashley?
Thank you all for having me. I'm very excited to talk to you all today about the immune system. So I am going to be covering what the differences are between the male and female immune system and how those look differently. And I'm also going to give you the biological background to relate to what my colleagues will talk about in terms of social impacts of COVID and also pregnancy. So the first topic I really want to talk about is just the overall immune system and the structure of that in the human body. So when you look at the immune system, you're really looking at two sides of the same house. So you have this innate piece of our immune system and an adaptive piece. The innate immune system is really going to look very similar across individuals. So these are things that they are there to keep you from getting sick. They're there to prevent the entry of bacteria and viruses and other pathogens, but they don't really ever improve. They never look any different from person to person. So for instance, the skin and the tears and your stomach acid, those are all examples of innate immunity that prevent things from entering. Now, if something gets into the system, you also have the cells that you all are seeing in that purple circle on your screen. And those are what we would term a second line of defense in the innate system, where something has breached the first initial line, but we still have this means of protecting the system. Now, these are going to basically look for things that are foreign. They find them, they mediate getting rid of those or alerting the other half of the immune system, but they never are going to improve. Now, when we talk about adaptive immunity, that's the really fascinating part of the immune system, because when you look at adaptive immunity, we all across the board look different. So your adaptive immune system is going to look different than mine because we have encountered different things along our journeys in life, and that's going to affect our adaptive immunity. Now, I don't want to get too much into the cell types because it does get pretty complicated, but I do want to highlight just two main types. So B cells are going to be found in what's called the humoral immunity. And B cells are extracellular. They are a cell and they produce antibodies, which of course are extracellular proteins. And that's going to have the purpose of stopping invaders before they can enter your cell and also slowing their movement through your body. So antibodies in and of themselves are just proteins. But when we're talking about viruses, what they're able to do is bind to that virus and prevent it from ever entering your cell. So they are essentially taking an active virus and making it to an inert particle. Now, the T cell system in the adaptive immune section is going to be a little bit more complicated because there are two branches. So in general, T cells are going to be either activating the system or protecting from a viral infector. So you see there's actually two main types of T cells in that middle circle there. And the CD4 positive, they're kind of the control of the entire system. They can work with B cells. They can work with the CD8 positive cells we also see there. But they're just the control. They're overseeing the action. The CD8 positive cells are going to take care of predominantly viral infections. So they are actually commonly called cytotoxic T cells. And their job is to kill your cells that become virally infected. So when we're talking about COVID, we're talking about a virus, and ideally we would see B cells going into action, keeping the virus from entering. But if it doesn't, the CD8 positive cells would then go into action. So when we look at invaders, there's a lot of different types of pathogens, but I wanted to just touch on the difference between viruses and bacteria because those are two of the most common that we hear about. So I'm going to start with bacteria. Bacteria are living organisms just like us. They have cells. They are unicellular, unlike us being multicellular, but they are able to consume products, create energy from the products they take in. They are going to be able to move around in certain cases. They are a full living organism. And with infections of bacteria, typically they're going to be limited to a certain area. So if you have strep throat, for instance, that would be a bacterial infection. It's going to be limited to your respiratory system. And from there, you're going to take an antibiotic. And unless it progresses because of complications, you're going to be well of that infection. When we talk about viruses, it's a little more complex because viruses are going to be taking over your cells. So viruses in and of themselves are not living. Viruses can do nothing on their own. They must have a human cell, if we're talking about a human virus, in order to carry out their infectious pathway. So basically a virus enters your cell and it takes over all of the machinery in the cell in order to take control and to make more virus particles that it can then spread. So with viruses, one of the interesting characteristics we see is that they are often systemic infections. And a systemic infection is going to be characterized by seeing symptoms that are not limited to one area. So with COVID, we've seen that most of the infections are milder. They're upper respiratory, lower respiratory tract, but we do know that there are some really interesting symptoms with COVID. For instance, skin rashes have been common in certain populations. You've seen that some people have strokes. There's been just really different presentations of this virus. And all of that is going to the fact that it's a systemic infection. It is affecting multiple systems because of the nature of that pathogen. Now, I wanted to include this quote as I move into talking about the male versus female picture of this. And when you read this quote, you see that they are giving a percentage of between 10 and 90% higher mortality rate in men compared to women. And this really makes a great point because there is so much we don't know about the SARS-CoV virus 2, and we're still learning, but we do know that there is a difference between how it affects males and how it affects females. So in other countries, not the US, we are seeing that there is a clear pattern that when you look at male to female infections, that males are going to have much higher rates of infection. And we are looking at many different countries in this one graph. These countries all handled their COVID control differently, but we're still seeing that same pattern. Now, when we move to the US data, this I really liked because it's separated out by age. And that's a really interesting trend that does align with the immune system of males versus females. When you look at males and females up to the age of 54, we see that there is a vast difference between male to female infections and female to female infections. And those are the ratios that are presented there. And that's going to be for two reasons. So when we talk about the female immune system, there is a genetic benefit to being female. There is also a hormonal benefit to being female. So that XX genetic arrangement is going to benefit us, and the estrogen and progesterone that come along with that are also very beneficial in terms of immune response. Now, as you look at this graph, you see as the age increases, that difference actually decreases. And that can be attributed to the fact that estrogen actually drops off in postmenopausal women. So we're losing that effect as women age, but you see that it's still a clear benefit, and that can be attributed to the genetic factor of having two X's instead of an XY. Now, this slide has a lot of immune type information, and I just want to briefly talk over this. When you look at the innate piece at the top, it looks as if men really don't have that much going for them in terms of a benefit. So you see that they have natural killer cells that are increased in the innate system, and neutrophils, which are a benefit. Those are going to be those first line cells that are helping to prevent infection. But when you look at the female side, you see that there are many more factors that are increased and contributing to that protection that we see in the female immune system. Now, in terms of the adaptive, I think this is a really interesting story. because when you look at the male immune system in the adaptive realm, we see that they have a decrease in B cell counts. And what that really gets down to is the fact that the male system is not going to most likely be as efficient as the female in stopping virus particles in the blood, because the B cell count is actually decreased. And that means that the antibody amount, and you see basal immunoglobulin and antibody response is also decreased. That just means that that first response of the B cells to stop the virus from entering the cells is going to be decreased. On the female side, we see that they have an increase in T helper 2, which is that Th2 section. That is going to be associated with B cells. So that tells us women have that increased antibody response, that increased B cell response. It's going to be protective and help to minimize that systemic effect. The virus can't enter the cells if it's been neutralized. And so that is going to be really helpful to the female immune system. Now this, I just wanted to highlight the XX and XY difference, also the hormone differences that we're seeing. So in females, we have the XX genetic arrangement. And that means that we have 2 copies of every gene that the X codes for. Now, there is a process called X inactivation, and that means that when you're going through your genetic development, one of the X's is going to go through an inactivation process that's going to turn off a lot of those products, because we don't want double doses of every single gene product. But studies have shown that the X inactivation is not completely getting rid of those double dose immune genes, and so females are benefiting from having more expression of genetic factors that give you the immune function. For males, when you talk about the XY, the Y does not code for the same things the X has. So males only get one X. So whatever immune genes they have are what's going to be expressed. The Y is not going to give them any increased benefit the way we see in females. The other thing we see in females is that we have, when we look at the ratios of hormones, we have more estrogen and progesterone as compared to testosterone. In males, it's flipped. They have more testosterone compared to estrogen and progesterone. And estrogen and progesterone are really significant in this story because your immune cells actually have receptors for these hormones. And that's going to mediate the function. And we know that in certain infections, it's been documented, estrogen present is increasing the activity of your immune cell function, and that's going to be very protective to you. This also plays a role in pregnancy, because we know that as you go through the pregnancy phases from implantation through pregnancy before delivery, that your hormones are going to be changing, and that's going to actually affect your immune cells and going to give you some of those characteristics we see in pregnant individuals. Now, the bottom part of this figure, I thought it was really interesting. It just talks about the pieces that males have more likely than females. So because males have a little bit lower immune function, they're more likely to have cancer or sepsis, which is an infection of the system in the blood. Whereas females, because we do have this overactive immune system compared to males, they're going to have autoimmune disorders more likely. And that's because our immune system goes into overdrive because there's more cells, and sometimes that can incorrectly happen and can lead to an attack on our own system. So it is a definite benefit, but there are some drawbacks, and autoimmunity is, of course, one of those. This figure, there's a lot going on, but I'm going to try to just summarize it pretty quickly for us, because Camilla, I know, is going to talk about pregnancy as well. But what we see here is that there are 3 different phases that we go through when a female becomes pregnant. So prior to implantation occurring, we are in what's called the pro-inflammatory environment. And this is the body really just trying to dispel anything that is infectious. Anything foreign is going to be expelled and seen as a foreign invader. And when you look, the bulleted list there, those are all cytokines, which are chemical messengers that are increasing that activity and telling the cells, go into action, fight off foreign things. But when you become pregnant, right after implantation, we know that the female body has to now accept something that is completely foreign to it. And when I say foreign, what I mean is that it has a completely different genetic arrangement than the mother does. Those are completely different genes, and the system is going to see it as foreign. In order to keep the body from rejecting the fetus, the fetal signalers are going to come in, and they're going to signal with the hormonal changes to the female's body that something has changed and we need to enter this anti-inflammatory state. And so that's going to continue for the 9 months of pregnancy. And what we find is that in some cases, that actually is a little bit of a detriment to the mother. If you think about influenza, pregnant women are always told get a flu shot because they're more susceptible to these infections because their immune function is actually decreased. But it's very important that it's decreased so that the fetus is protected. Now, after delivery, you're going to see that graph ramps back up. We go back into pro-inflammatory, and that effect is actually going to go away as the hormones go back into balance and the fetal factors are removed from the system. Now, the last thing I want to talk about is what's called the cytokine storm. And this is a little bit of a preview of what Yaba will be talking about. But when we talk about cytokines, that word simply means chemical messengers. So these are messengers that the immune system cells put out in order to mediate their response. So it could draw more cells to the system. It could draw other chemical messengers in. It could vasodilate the vessels, meaning expand them or constrict them. So lots of different things go on with these cytokines. But when we talk about a cytokine storm, what that means is that we have just an out of control response with the immune system where the cells are just releasing a lot of cytokine going all throughout the body and signaling the immune system to respond. And some of the effects of this are clotting. And I think we can all probably understand why clotting would be a negative throughout your body. That's going to slow the spread of blood as it clots. That's going to lead to things like shock and organ failure. So we see renal failure is one of the first that would occur because it is filtering the blood and there's a large blood volume going to it. You can also get lung injury. When we talk about COVID-19, lung injury is a big part of this, especially when people enter what's called ARDS. That's a the lungs have basically been destroyed in that acute respiratory distress syndrome. And that's part of this cytokine storm piece. And with that, you're going to get lots of inflammation throughout the body. You're going to get organ failure. You're going to get just the infection being spread throughout the system. And all of that, if it's not controlled, can lead to death. And that's a really, really big part of this COVID-19 story. One we don't fully understand, but of course, one that is of great concern as we look at treating patients with this disease.
Thank you, Ashley. Thank you for sharing. As Ashley said, up next we have Dr. Yabo Obasanjo.
Yes, hello everybody. My name is Yabo Obasanjo. I teach at the College of William and Mary. I have a PhD from Cornell University in epidemiology, so I'm an epidemiologist, and my minor was immunology. So it was very interesting to hear Ashley's part of this presentation. I'm going to move forward from where Ashley left off and just kind of look at COVID-19, moving from the biology part to society in general. So Ashley already talked about the autoimmune system, the autoimmune reaction that females have more than men. So this is just a list of some major autoimmune diseases. And as you can see, this is the ratio of female to male that get the disease. And you can see almost each of them, there are more females that get the disease than males. The exception is psoriatic arthritis, which is 1-to-1, and ankylosing spondylitis just behind it, beneath it, that has actually more of males having it, and that's a joint disease, and that has to do with muscle mass, which is why males have. But in general, we know, and in medicine, that women tend to have more autoimmune diseases than men. And some of the things Ashley talked about is the reason why. The fact that women have to carry a baby for 9 months and not rejected. So that means that our bodies have to have a complicated immune system that must, at some point in your life, not reject a foreign body, and at other times reject it. So that makes it a little bit more complicated. And of course, the hormones are also part of that, regulating the estrogen and the progesterone also regulate immunity, meaning that it's kind of a complicated immune scenario for women, much more complicated than men have. And again, that leads to a lot of issues with autoimmune diseases. Lupus is one of the big ones, but almost all autoimmune diseases occur more in women than in men. Ashley has talked about this X-linked genetic factors. She has also talked about the hormonal factors. What then this leads to is that sometimes the hormones regulate the disease so that it doesn't appear as severe. And she talked about when estrogen drops, we know that there are lots of diseases in women that increases after estrogen reduces after menopause. And I saw one question about estrogen replacement, so I'm going to kind of answer that. A lot of studies have already been done on that, and estrogen replacement after menopause is actually not advised now because it increases other cancers, reproductive cancers like breast cancers, because the receptors for them then stay on. And also, so yes, estrogen is good for the immune system, but you don't want to replace it as estrogen itself, because it will also increase risk of cancers and turn those risks to that of men, which we know that men usually have some cancers at higher rates. Some of the factors are men and women differ in their subjective experiences. And what this means is that when you ask women about pain, and men about pain, a lot of times women will answer about pain, even if it's the same pain level. We know pain is a subjective assessment. We have no objective measurement for pain as of today. So that subjective measurement means that when you ask, women tend to tell you about what they're feeling more, so that when you ask men about pain, you are probably not getting the same answer. And so that's one of the reasons we have these differences. The measurement of the diseases are not neutral. What that means is that we might tend to ask women about their immune disorder because we think, or just their pain and life experiences more than people ask men. People tend to discount pain in men more than they do in women. Men and women are treated differently in society, and we respond to treatment differently. A lot of studies have shown that some women tend to actually respond to intervention, to medical intervention, and follow medical interventions and advice than men do. And all those kind of lead to this higher prevalence we found of autoimmune diseases and immune regulation in women. Sex imbalanced exposures. What this means is that we don't know everything that triggers autoimmune diseases, but we do know that there's some chemicals that do. And sometimes because of the societal differences in ways men and women work, that there might be some exposures that are linked to what women do, maybe household chemicals, maybe cleaning chemicals, that might be leading to higher rates of prevalence in women. So how does this all affect COVID-19? Ashley and I now have talked about this hyperimmune function that women have, which is complicated because of all these things the female body has to do, keep the baby, not expel it, but every living body also has to reject what is not self. So, and so it's kind of trying to balance that. So that hyperimmune system seems to be protecting women in COVID-19. But the societal role that women have might be playing a deleterious effect for women in this pandemic. And I'll go more into both situations. So to discuss COVID-19 a little bit more, it's a coronavirus. That was the first name we got before we actually had a name for the disease. So COVID-19 is the name given to the disease, and it just means coronavirus disease, and the 19 was because it was discovered in 2019. It's an RNA virus. We have two kinds of viruses, DNA and RNA viruses. RNA viruses are simpler. They're single cell organisms. They're not single cell per se, like the bacteria, but they're single cell. They need a living cell of some kind to survive. That is why the virus outside the body usually at the most the last days or even hours, most actually are last hours. They need one living cell to another. that they can infect. Other diseases caused by coronaviruses are the common cold, SARS, which means serious acute respiratory disease, and then MERS, which is Middle Eastern Respiratory Syndrome. So SARS is serious acute respiratory syndrome, and MERS is Middle Eastern Respiratory Syndrome. And I'll talk a little bit about the two more because they are the two diseases most similar to COVID-19. And the common cold, the coronavirus that causes the common cold is thought to have adapted to human for over 1,000 years from another species, so that it's over time, and this is how diseases work in different species. It's adapted to us over time that it causes mild disease. One of the ways we know a new disease is new to humans is that it causes serious disease, and it kind of kills at a higher rate. When the disease has been with us over time, it tends to moderate itself and reduces its fatality. So basically, I'm going to answer the question that came up because it's very important. It said, is MERS the same as MRSA? No, though MRSA is staph resistant. Cause that is resistance to antibiotics. Middle Eastern Respiratory Syndrome, I'll talk about it a little bit more about the two, about SARS and MERS. They are viruses. That the MRSA is a bacteria. They are very similar to the SARS virus that causes COVID-19. SARS, which is and the names of the two viruses are now SARS-CoV-1 and SARS-CoV-2. COVID-1 is just SARS coronavirus 1 is the SARS virus. SARS coronavirus 2 is the COVID-19 virus, because both of them cause serious acute respiratory syndrome, which is why the SARS is still in the name. Both of them are derived from the bad coronavirus. People have asked, why are we so sure it's derived from the bad coronavirus? Because we know the genome, and it was in December 31st of 2019 that China released the genome, and that was when they were able to declare this is a new virus. This is a novel virus. We do not have any other. We have not seen this virus before. But they were also able to show that it is 80% of the genome is the same as the virus that caused SARS, which is and so that was that caused the SARS, and SARS outbreak was from 2003 to 2004. And that virus came from a bat. It is closest in genome to a bat coronavirus that is almost like the common cold coronavirus to us, to the bat. So bats have it, it doesn't kill them. They have some symptoms, and that is the bat coronavirus. That bat coronavirus now twice has changed to infect humans in two different ways. So right, the first time it changed in a different way. This second time it changed to infect humans, it changed in a different way. Usually this occurs over time, and over time with contact. So why is this happening more and more? Part of what people think is that because wildlife, their natural habitat, which is forested areas, are being cut down so much all over the world, that all the organisms that actually have natural hosts as wild animals are looking for new hosts, and over time are changing. And because there are lots of humans, there's 7 billion of us and growing, it's trying to kind of find a new host. And so it's a natural phenomenon. It's something that has always been with life on Earth, and they will change, and we are putting pressure to make them change faster. So what does the coronavirus cause in the body? One of the things it causes, how does it enter the body first, is that it enters through the mucosa of the nose and the mouth. It does not enter the body through intact skin. and it hasn't been shown to enter even through a cut in the skin. It has to enter through the mucosa of the mouth or the nose. There's some evidence that it might enter through the mucosa of the eye, but the mucosa of the eye is not exposed to the outside as much as our nose and mouth. So we know that. That's how it enters the body. It replicates in the mucosa and then slowly moves down the respiratory system. When this is happening, you probably won't have any symptoms. Those are the asymptomatic, but it's replicating. When I'll look at the next slide and I'll tell you whether we're not sure when from that initial infection, at what stage we can actually detect the virus in your mucosa. Because that is where we're looking for the virus and to say you have the virus or not. So the initial symptoms that have been found in this early stage is that there's a loss of smell, which is, of course, it's there. It's kind of affecting your upper respiratory system. This is when people have the dry cough and then they start to have fever. And the fever is just the sign that the body is trying to get rid of the virus. It's already detecting this foreign body, and from the fever, the immune response starts to show. But again, all these symptoms differ from individual to individual. Then it progresses down to the lower respiratory system, which is the lungs, and this is where actually the problem starts. For a lot of individuals, and we don't know the reason why yet, the disease stays in the upper respiratory chamber and they have mild symptoms and they never get sick, really, or they get a mild sickness and they're better. Then when it gets to the lower respiratory tract, to the lungs, it causes a pneumonia, which is just the fact that the lungs are infected. A lot of diseases cause pneumonia. And but we're going to talk a little bit, I'm going to kind of go back to what I talked about. And this question mark here is what I just mentioned about the fact that after the disease, someone is infected, there's a pre-symptomatic stage in which you're probably infected, but you're probably not also infectious. That means that you have the virus is figuring itself out, but you're not shedding it yet. If you sneeze, it's not coming out, and then you enter the viral phase. We do not know exactly how long this is, or even if it exists, but people are assuming that there must be a time when people are healthy. But we know that from the time we can detect the virus, you are infectious. And then there's a viral phase, and then there's the cytokine storm. The cytokine storm is where the male-female differences start to show. What happens with the cytokine storm that Ashley described is that the lungs are infected with the virus and it's a foreign body. So all the immune responses, the body starts to send the cytokines. The B cells, the T cells are sending out messages, and the cytokines are the messages saying, go destroy this organism. But the organism is in a human cell, is in a lung cell. So to destroy the virus, the cells have to be destroyed as well. When there's an overreaction, what the cytokine storm does is that it's killing so much of the lung cells that the pneumonia is actually getting worse from the immune reaction itself. Then a lot of people that die during the cytokine storm stage, in which the pneumonia just becomes, just from the disease, and the cytokine storm itself causes the fact that they can no longer breathe by themselves. They have to be on a ventilator, and the lung tissue is destroyed so much that it becomes impossible to survive it. And of course, the lung function is to get air, oxygen all over the body. So if there's no oxygen moving around the body, you have cell death in all the other organs around the body, and before you know it, the body starts to shut down. This phase is when a lot of women do not get the cytokine storm. For women that generally have an hyperimmune system as women, the response to the virus in the lung tends to be muted, so that instead of the body trying to kill the virus and killing lung cells as well. It doesn't do that. And what happens then is that the pneumonia resolves over time by itself, and you still have enough lung tissue that can survive. And so this cytokine storm, and why women don't get the cytokine storm as much, is not fully understood. If you survive the cytokine storm, what can then happen is a next phase, which is a coagulation phase, in which and this is the phase where we found out that people have strokes. And this phase might seem that there is either more women or men and women, but then the difference is not as in gender, is not as big as during the cytokine storm. Then if you keep going and you survive, there's a late hyperinflammatory stage, which is what you now find that a lot of children, that all this was not detected, the children now have some hyperinflammatory disease that has to be managed. And then of course it goes if it's managed well. So there are different phases we're finding out. And just today, a steroid that is an anti-inflammatory was found to be very effective in treating the disease. And it's this stage that steroid will work against. It's working against this hyperinflammatory process of it, which again also can cause mortality. So I've talked about the lungs, I've talked about the cytokine storm and how it destroys, how the virus and then the cytokine storm itself have negative impacts on the lungs. So the body wages its own war against the virus, but in doing so, kind of compounds the pneumonia. The pneumonia continues, there's less oxygen for the body, there's multiple organ failure when the lungs can't get oxygen in and distributed. Again, mentioned women mount less of immune reaction in that cytokine storm and tend to survive that period of the disease pretty well. So this is a newspaper article from The Guardian, and I liked this quote. It said, while men are dying more from the pandemic, it's women who suffer most while living with the pandemic. Why is that? Women are exposed more at their jobs. About 90% of all healthcare workers worldwide are women. And in the US, this goes from everything from certified nursing assistants to RNs to every kind of care that involves taking care of the sick is predominated by women. And in diseases where health workers are exposed, and this includes Ebola, this includes SARS, this includes COVID-19, health workers tend to get the disease because they get it from patients. You have this issue of women being exposed through their jobs. Part of it also is economic. Women tend not to have, if you look at professional jobs in which people can work from home, for example, and are not service jobs, women predominate. And so when you have a shutdown and a woman cannot be a hairdresser, she cannot do nails, she cannot service people, then you're going to have that shutdown affect women's livelihoods more than men. And we're seeing that. Part of also the information that is being gathered now is that with the homeschooling and childcare, with people being at home, women again are kind of the ones predominating in the home, doing those jobs, which would have been balanced if they were at work and couples were at work. And so one of the things that has been found is that since the shutdown, scientific articles from women, which for me was a surprise, has reduced in percentage. Women are submitting less scientific journals, and they found that this was probably due to the fact that with women being home, they're doing the childcare and they're not able to progress in their research and in their work. It seems like simple things, but it does affect how people then get ahead in their profession. Women work a lot in cash-only jobs, in which it's not captured by the economic terms. And then a lot of these jobs that women have are service jobs. A lot of what they also live on is tips. And when those tips are not really calculated, when stimulus packages are being done for population, it compounds the economic problem for women. Shutdowns in general have been found to affect women economically more than men. And this is now being found in almost every part of the world. Some things that have also come out is, for example, in the US, states, a lot of states declared, I think there were 13 states that declared that abortions were non-essential health services, which in essence means that women that wanted to have an abortion that for whatever reason could not have them. The problem with that is that if you delay an abortion for a month, it really makes a difference whether you can have it or not. So basically, women's lives literally changed in several ways because of this pandemic. There are other things like in poor countries, immunization stopped because people immunizing kids could not go house to house because of the physical distancing issues, and all kinds of other issues came up. In general, infectious diseases affect women more because we care for the sick. Women tend to be the one caring. So in the house and as a profession, if you are more in contact with sick people for infectious diseases, we are more likely to get them. A lot of infectious diseases that are human to human. In poor countries, women go out and fetch water. There are lots of diseases you get from just putting your feet and your hands, especially your feet, in water. Everything from guinea worm to schistosomiasis, onchocerciasis. I'm not going to, but those are actually parasitic diseases that you get from water, from stepping into water, and then they infect you through the water into your feet. Caring for animals. I'll talk a little bit about MERS and SARS in my next slide, which is my last slide, because MERS is from camels, and camels and big animals, cows, tend to be tended by men, but chickens and goats in low-income countries tend to be tended by women, and that also puts women at some risk of some diseases that are zoonoses, and zoonoses are diseases that can pass from animals to humans and humans to animals. Lack of knowledge, women tend to have less education, and so if you do not have the knowledge, you do not know how to protect yourself. Education is related to risk of diseases, from infectious disease to non-infectious diseases, because the more you know, the more you can take care of yourself. So that is part of it. And even with the COVID-19, we're finding that when people cannot read, they cannot understand. When you put out public announcement, if you do not put it in local languages and languages people can understand, or if you put it as reading materials that people cannot read, it will affect certain part of the population more. Less access to treatment. We know in a lot of societies, women need to get permission from husbands and different social access, or even money. If you do not have money, you cannot access help. Okay, this is the slide I've been promising, where I will talk a little bit more in depth about SARS and MERS. So SARS is the SARS-CoV coronavirus 1, which is, it's very different diseases. It's a different virus, and it was first detected in 2002. The interesting part is that it was detected in November 2002 in China, but in a different region of China, in Guangzhou, China, where COVID-19 was first detected in November 2019 in Wuhan, China. Both regions are in the eastern part of China, and both are economically actually developed parts of China. They affected more women. SARS affected more women than men, but men died more. Again, it seems that the viruses are very similar, so the biology might be the same. Unfortunately, SARS started in 2002, November. It spread around the world. This RO number here is the number of people one person infected on average. And so one person infected about 2 to 4 people. It went around the world. Eventually, there were 8,000 cases and about 800 deaths when it was all totaled up. But it disappeared. So this is part of the problem. When COVID-19 started, that people were saying it will disappear, and it's by November of the next year of 2003, it was all gone. And I think the last case actually got better around January of 2004. And that last case, it just disappeared. So there was this idea, the research stopped, all the work, all the countries that actually had SARS as a huge problem, which were mostly in Asia, but Canada also had quite a few cases. They were really, what it turns out was that disease gave people almost like a dry run for COVID-19. And all those countries that really had hundreds of cases have been able to react to COVID-19 in a very much more active and way than countries that did not have SARS. And the same goes for Ebola. Countries that had Ebola were able to just reactivate that public health system they had in place, the contact tracing, everything, all over again very easily. So the COVID-19 is kind of teaching us a lot in public health about responses to infectious diseases. MERS is, again, Middle Eastern Respiratory Syndrome. It was first reported in Saudi Arabia. It is from camels. Again, SARS and COVID viruses came from the bat coronavirus. The MERS virus is the natural host is the camel. And the first cases were people that were camel handlers. It infects less, every person infected infects less than one person. So it's not a very infectious disease. The reason we know a little bit about MERS more than we ruled out, because it's really a sporadic disease. You have 1 or 2 people, was that there was an outbreak in South Korea in 2015, in which one businessman that went on a business trip to Saudi Arabia went on a tourist visit to where you can climb camels as a tourist. So he petted the camel, climbed the camel, went back to South Korea and got sick. And it's a very, if you actually read the story, it's a very, very interesting story in public health and how South Korea kind of controlled that disease, because the gentleman was going from one hospital to the other, and even in the waiting room, it was infecting people because he didn't know what was wrong with them. They didn't know. By the time they diagnosed, it had become a general disease. So that was the biggest outbreak of MERS that we've had. And again, how that has been stopped. SARS, we don't know what really happened. It just seemed to, and we do know what happened was that all the countries where SARS got to, they kind of clamped down in a public health way, which is you do your contact tracing, you quarantine. They did everything that needed to be done. For MERS, that was what South Korea did to end the outbreak. But overall, Saudi Arabia and all countries in the Middle East that actually have camels, even for pets, what is done now is that there's a test for the camel, and if there's a camel that is positive for the MERS coronavirus, it's put down, so that's how we've been able to stop the spread. The last MERS outbreak is actually in Sudan, which also has camels, but they were not doing testing. And I don't think Sudan does testing up till today. So there was an outbreak, and that was controlled. All the camels that had been exposed to that one camel were tested and put down, and the people treated. But MERS, we do not expect will become a general disease without control system in place. COVID-19, this is where we are now. as of today, we feel that one person infects 2 to 3 people, and that changes by region. Of course, it changes by exposure. If that sick person is found on time and quarantined, they do not infect that many people. As of today, this is from 2 months ago, this data I have. Today, of course, it started in China in Wuhan region. The number of infections as of today, I wrote it down, is 7.8 million confirmed cases around the world, 7.8 million. So this slide is from 2. And the number of deaths as of today is about 430,000 people deaths, confirmed death, 430,000 confirmed death. So that's where we are. And at this point, I will hand over to Camilla.
Thank you, Iyabo. Thank you very much for your presentation. So as Iyabo just shared, we have Camilla next.
I'm really, really honored to be part of this presentation and happy to tell you a little bit about pregnancy. So we know that women who are pregnant in the first and second trimester do have a slightly increased risk of miscarriage. There also is a slightly increased risk of preterm birth. There's no evidence whatsoever that there's vertical transmission from the mother, in spite of the fact that she has the virus in her bloodstream, to the fetus. So for this, we're very grateful. And strangely, because it doesn't follow what other viruses do, this particular virus does not seem to have a more severe clinical course in pregnant women than in non-pregnant women or in women in general. And this is unusual because, as Ashley mentioned earlier, influenza is much more severe in pregnant women. Measles is more severe in pregnant women. Chickenpox is more severe in pregnant women. So the typical viral infection is more severe in pregnant women. That is not true for COVID-19. Next slide. Everybody who has who's either pregnant themselves or has a daughter or a daughter-in-law or granddaughter who's pregnant is really worried about delivery. What are we going to do when they go into labor? Is that going to put the mother at risk? So in communities where there is a higher prevalence of disease, we may do SARS testing with the woman when she's admitted to labor and delivery. For women who test positive, cesarean section is not recommended to prevent transmission because there doesn't seem to be any transmission, increased risk for transmission during the birthing process. So a normal vaginal delivery is the goal for all pregnant women. And that is true whether you have the SARS infection or not, whether the COVID infection or not. Next slide. And this is, I think, really good news. After birth, if a mother is positive, now we're talking about positive mothers. If a mother is positive for COVID, she actually has the infection. If she is well enough to take care of her baby, there is no need to separate the mother and baby. What she needs to do is she needs to be masked and she needs to use excellent hand washing technique, but she does not need to be separated from her baby. And breastfeeding is permitted. In fact, breastfeeding is even encouraged. Again, with careful attention to hygiene. There's no evidence there's any of the virus in the breast milk, which is not true for HIV, but it is true for this virus. So viral diseases are really, each virus is its own unique pathogen. Next. And breast milk, as you all are probably well aware, contains some very important immune boosters. So it is really important for a newborn baby that is born with an immature immune system to get those immune boosters from its mother. So there are 4 different types of immune boosters in breast milk, and we definitely want these babies to have that opportunity to be breastfed. So that's another piece, I think, of good news. There's not a lot of good news about COVID-19, but the news for pregnant women actually is kind of encouraging. And as an obstetrician, that makes me very happy. So I'm sure that in this time when we're reopening our economy, we're all wondering how can we decrease our our own personal risk for infection. And of course, we're family members. How can we make sure that we keep our families safe? So how do you get infected? You get infected when you breathe in a certain amount of virus. And how do you get that certain amount of virus? It's respiratory transmission, so you have to breathe it in, and the virus has to be in the air around you. So the amount of virus in the air around you times the amount of time you're exposed to that air is going to determine how much virus comes into your system and whether you get infected or not. So let's look at respiratory spread. So when people talk, just normally talk like I'm talking, you may not have thought of this before, but now in the COVID, everybody is aware that we expel from our mouth in ordinary conversation droplets of spit. And these droplets fall to the ground depending on how heavy they are. The bigger they are, the faster they fall. Most respiratory droplets fall to the ground within 6 feet. There are a few tiny droplets called droplet nuclei that float around in the air. If you were ever a chemistry major or a physics major, you may be familiar with the term Brownian motion. These tiny, tiny, tiny little nuclei are kept suspended in the air. Think about when you bake cookies. How does that aroma get throughout your whole house? Well, they're little particles from the cookie that gets into the air and gets suspended in the air. So those are droplet nuclei. And when you talk, some of those droplet nuclei are expelled also. How important are the droplet nuclei in transmission of this disease? We honestly don't know. What we do know is most people who get it have got it by close contact within 6 feet, that they've had conversations with people they didn't realize that they were infected. People who themselves who had the infection probably didn't realize they were infected, and they spent more than 15 minutes. So if you are without a mask next to a person who has the disease, they don't know they have it, they're acting normally, behaving normally, and you engage in conversation with them closer than 6 feet for more than 15 minutes, that's your highest risk of getting this disease. And the real problem here is that, no, you can go ahead. The real problem is that we have this time after we're infected and we are expelling the virus, but we don't feel sick. And we don't know how long that period lasts. It may be 1 day, it may be 2 days, it may be 3 days, but public health officials believe that that is when most of this virus transmission outside of healthcare facilities takes place. So what can we do to protect ourselves? We can wear masks. And if we wear a mask, we reduce our chances of getting this virus by, we believe, about 80%. So wearing a mask is really, really important when you're anywhere except with the people that you've been living with. So here we have, on the very top, you've got the infected asymptomatic person expelling all these droplets. And if you are near this person and you have on a mask, you're really reducing your chances of breathing in those droplets that contain the virus. If you don't have on a mask, your chances are dramatically increased the closer you are. So if both people have on masks, that really dramatically reduces the amount of virus in the air and hence the dose of virus that the uninfected person will inhale and reduces their chance of getting infected. Next slide. So let's talk about face-to-face conversation. Lowest risk, highest risk. If you're more than 6 feet away, most of those droplets fall into the ground. If you have a short conversation, hi, how are you, as you're walking into the grocery store, probably not going to get an infection. If you're outside, the particles are dispersed in the air. And if you have on a good quality mask, and the mask is worn so that it really covers your nose and your mouth and fits as tightly as possible. Next slide. Shared spaces. If you're in a room inside and there are few people, that's much better than if there are lots of people. Probably not going to be a good idea to go to church for the next year. I hate to say that, but that's probably the truth. If you're in the shared space for a brief time, that's helpful. Longer times, if you, for example, if you're in church and your church lasts for an hour, that's a lot longer than 15 minutes. And then you actually have a chance to inhale those nuclei that are suspended in the air. If you're outdoors, the droplets are dispersed as opposed to being indoors. And this I think is really interesting information. Gymnasiums, your gym, your local gym. Local gyms have really great air handling and they turn over the air really rapidly. Why? Because before COVID, they did that because if they didn't, the gym would smell really bad. And if you pay more than $50 a month to go to your gym, you do not want to go to a smelly gym. At least I don't want to go to a smelly gym. My gym smells great. I know they have really good air handlers. And so, yeah, I might be tempted to go back to my gym. And then again, high quality masks. That's a recurring theme. Next slide. So these are your 3 dimensions of risk that you need to consider. The more crowded the space, the higher the risk. The more enclosed the space, the higher the risk. And the closer contact that you have with other people. So those are the 3 things that you have to consider. You can think of risk as a 3-dimensional space that you can move on all these axes. Next slide. So now, how do you assess your risk? We're family members. We want to go see our parents. We want to go see our children, our grandchildren. We want to go see our siblings. We may need to return to work. And we want to see our friends again. So how do you decide what you're going to do? You need to assess your own risk, and then you need to assess your risk in terms of how bad would it be if I got the virus? I'm 75 years old. I have some health issues. So if I got the virus, I'd have a high risk of getting a severe case. My 30-year-old daughter, on the other hand, if she got the virus, probably would do pretty good. So there's really an age gradient and there's a health gradient. So if you're in really good health and you're younger, getting this virus is probably going to be unpleasant, but not deadly. So when you're trying to decide if you should visit somebody, you need to think about your own personal risk of getting the virus from them, and then your risk of unconsciously transmitting to them in case you are incubating a case of the virus. So these are the things that you need to consider. In terms of going back to work, enclosed spaces, you really, really want to avoid enclosed spaces if possible, or make sure there's good ventilation. Okay, last slide, please. So what's my best protection advice? Avoid the 3 C's. Avoid closed spaces, avoid crowded places, and avoid close contact. If you're going to visit with your friends, do it on an outdoor patio. Don't do it inside your car with no masks. And when you're in public places, both indoors and outdoors, wear a mask. It protects you, it protects other people. And follow the advice of your public health officials because they know how much community spread is going on. The more community spread, the more careful you need to be. Right now in James City County, mercifully, even though James City County, which is, Williamsburg, James City County, unbelievably, in the early week of March, the first week in March, James City County was the hotspot in the entire state of Virginia. We had more cases per capita than anybody. Now, over the last 12 weeks, that has really dropped off. And now every day we have maybe 1 or 2 more diagnosed cases, but very little community spread in James City County right now. So I'm feeling pretty good. So it is really important to keep up with the public health information that is readily available to you online from your local health department. And with that, I'll conclude my remarks and we'll begin to take questions.
Thank you so much, Camilla. And thank you to Ashley. Thank you to Iabo. And now, as Camilla shared, we have Val Cushman, who's been keeping an eye on the chat function. And so she'll read your questions and then we'll open the floor so that you can ask some aloud for our last 15 minutes.
There are a lot of questions. I'm not sure that we'll get to all of them, but I'll start with one of the latter questions, and it has to do with seasonal impacts and the masks that we choose. So it's a 2-part question, and I'm not sure who would be the best person to answer it, but it's how do you tell the quality of a mask? How do you factor in the seasons and the heat and the humidity that will come with summer? And in general, what should we be thinking about as summer and the seasons change? Anyone want to take a first stab at just helping us learn a little bit more about how we choose our masks?
I'll answer the seasons. It's really easy to answer the seasons questions. The answer is we don't know. When you have a novel virus, we don't know. I mean, if you would ask me at the beginning of this, would COVID be a disaster for pregnant women? I would have said, of course, because that's the way viruses behave. So all bets are off. We have no idea what the seasons are going to do.
I just want to add to that. That's an ongoing area of active research, because one of the suppositions is that African countries have generally had less cases than expected just because of the high level of poverty. And one of the things people are thinking is that the heat and the humidity, that the droplets go to the ground faster. All that is not, that when it's dry, they spray out more. And that when it's humid, they kind of fall to the ground. And so that's one. And part of it also is that when you have people sleep indoors in Africa at night, people open their windows. There's cross ventilation. The houses are kind of built for cross ventilation and open air. So all that is still unknown, but there's probably outside factor. We know that outside is safer than indoors if you're around an infected person. So weather must play a part somehow.
And I think just to address the type of mask, I saw a comment actually address this as well. We need to save the N95 mask for the people who are on the front line. So the healthcare workers who are seeing the cases, treating those patients, but the evidence has been out there and is widely distributed that just a face covering is going to be the best for the common Americans who are not in a healthcare setting. And like Camilla said, it needs to cover your nose, it needs to fit against your face, and it needs to go under your chin so that you're limiting that spread as much as possible.
Thanks, Ashley. And Ashley, while we have you engaged here, a question was posed early about supplements or food that might help women's immune systems.
So when you talk about the immune system, we have to remember it's not just one single thing. There's lots of different components of the immune system. So when you look at boosting the function, it's really just a healthy lifestyle. So eating the leafy green vegetables, eating those colorful fruits, the vegetables, those are going to carry the nutrients that those cells in the immune system need. So for instance, iron is going to be great for the immune system. Spinach is a great source of iron. If you're looking at B6 is another vitamin. Pork, chicken products, cereals even have that in it. So eating a well-rounded, healthy diet is going to be the best option. When you talk about supplements, students will ask me about this a lot. I caution them to be careful because we don't always know what's in the supplements. And that's because they're not always regulated very well. So if you can eat your vegetables, eat your fruits, get those vitamins from your food sources, that's going to be your most ideal way of doing this. And we also have seen evidence in the research that the food products that have those vitamins are going to get those into the body more effectively than popping a supplement pill that maybe is not being processed the same way by the human body. Another piece of this is really decreasing stress levels, because that is one thing we know for a fact is going to decrease your immune function. When you're stressed, cortisol is a different hormone that's going to be released, and that's going to inhibit the immune function throughout the body.
Well, all three of you have helped us in that regard, because the more information we have, the less stressed we are, and hopefully the healthier our immune system. So thanks. A question came in about the additional risks for older people, and whether it's related mostly to underlying health conditions, or is it more just a matter of general decline in the immune system overall?
I'll say both. It's both. Definitely, there's clear evidence from death rates and death records that if you have an underlying chronic condition of any type, whether you're young or old, it puts you at higher risk. And there's clear evidence that the older you are, and then of course with the combination of the underlying condition, that you're at higher risk. So age in every country so far, older people have had higher mortality rates than younger people, and the mortality actually graduates with age for every age group. And I think Camilla might add to that, but that's the general trend.
No, I agree with you completely.
All right, and Yabo, this question may be for you as well. A question that came in earlier, whether immunity is solely linked to genetics, or if it depends on hormone levels. For example, would different people have different immunity based on natural hormonal differences? Or put another way, would a trans woman gain immunity if going through hormone therapy?
Oh, that's a complicated question.
Yes, yes.
And the way I'm going to answer is that we know so little about transgender health today, because it has not been, the effect of male hormone in a genetic female and the effect of female hormone in a genetic male have not been well studied yet. So I cannot answer that question, because anything I say will be really an opinion, not science.
All right, thank you. Camilla, this one is probably for you. Is the immune response different in women who have been pregnant versus those who never have?
I think that is a really excellent question. And honestly, I don't know the answer. Ashley, do you have any?
So the research that I have read basically just groups it into premenopausal and postmenopausal. And part of that is when you're doing the research into this, it's ethically not okay to infect women based on their cycle, and would be very difficult, to be frank. So when we know that the estrogen amounts are changing based on cycles, that would be a really tricky research project. But what we also know is that women before pregnancy have hormones that are in certain levels. After pregnancy, they have them in those certain levels. And it goes back to very similar as before. So I think that it would not really make a difference. And there's not really been studies that have shown that there is a difference of being pregnant versus not, and that affecting your immune function. It's really the estrogen amounts and the progesterone compared to the testosterone levels in premenopausal women.
All right. Thank you. Someone has asked the question about very young children. We've asked about older women. What about very young children and their risk? You know, weeks and months old. How does that compare?
So far, it looks like the inflammatory disease that children have was actually 2 months ago. There was no data. All the data was saying that 0 to 9, nothing. And now we're here where it's coming out that 0 to 9, you have this inflammatory condition that children can have that can be very serious, but can be very well treated. And so there is that. for babies, there really is very little or no information at this time. I will not even, because of what we've now known with children, I would say we don't know with babies that are under one, for example.
And I'd say I think that's kind of surprising. When, you know, I wear two hats. I was a clinician for 30 some years. And then while I was still practicing, I went to public health school and got a track in epidemiology. And so when I really don't know the answer, I like to sort of fall back on the epidemiology, which is just the basic statistics, the descriptive statistics. And what we know about children under the age of 1 is there have been very, very, very few deaths and very, very few documented infections. And personally, I find that surprising, because I know that children under the age of 1 don't have a completely developed immune system. They don't respond very well to immunizations, which is why you don't immunize your child to measles until they're over the age of 1, because they don't respond to that immunization for measles very well. So I find it puzzling, but the honest answer is we really don't know why there seem to be so few children. You'd think that there would be more, but just looking at the statistics, there are very few children under the age of 2 that have been infected, and very, very few who were infected have actually had serious infections. So that's reassuring. We can't tell you why, because we're still learning about this virus, but we can tell you what and who.
Yeah. Well, let's move up
That's
the age bracket.
Of epidemiology, by the way, which is a subject I absolutely love.
Yeah. Well, moving up the age bracket a little bit, we've talked about older and the very young. Of course, we are all looking for answers around children returning to school. We have some questions from teachers and no doubt from parents and maybe grandparents who are starting to think about August and September. And I guess I would throw summer camps into that mix as well. I know there's no magic answers here, but any thoughts about return to school and things that are on the mind of our experts around that topic?
As all three of us are going to be exposed or working with the young adult, and we've had to think about it quite a bit. For me, the young adults are not, most of them are actually, if they do get the virus, are not going to show symptoms. From the data coming out, people between the ages of 18 and 22, 23, which is the college age kids, 90% of them are not going to show symptoms, even if they're infected. So even if you have an outbreak, until it reaches a person with a compromised immune system, you're not even going to detect it. That's with that age group, you're not going to know. I think that for schools, it's going to be testing with symptoms that is the best way. Mass testing, you're going to get so much, you're going to do so many testing for so little result. But symptomatic testing will probably be and kind of making people aware that once you have the first symptoms, that morning you wake up and you don't feel good, we test and kind of start to divide. Most of the times it will be false positive. Most of the people waking up feeling bad, it will be the usual suspect, a cold, the flu, but we will be able to detect a lot of cases. The people that are going to be at risk are the teachers, particularly the older teachers. And so again, if you go back to that three-dimensional diagram of how to minimize risks, the schools are going to have to adapt to minimizing risks for their staff and their teachers by having particularly as much as possible, self-contained classrooms so that you meet the same 20 kids or 25 kids every day. For God's sake, send the kids out to recess. We're just going to muddle through it. We're going to muddle through it because having children stay at home in 2 years is absolutely unacceptable.
And I think too, I mean, this is the younger the children are, the harder this is because they don't understand. As a mother of a young child, I cannot make him understand why masks are important, but I think we just, as educators in higher ed or K-12, we really just have to do the things we know that work. Wear masks, wash hands. If you're symptomatic, stay home. And I think the decisions have to be made based on doing the things we know are effective with this virus.
Excellent. I'm going to pose two more questions. One is really quick. The other one might take a little bit more to answer. So the first one is around going back to masks. How often should they be cleaned? And does a plastic shield necessary, more effective? Do I need both? Questions around that plastic shields and frequency of washing.
So with the mask, I think it's a really good practice, and what I've read on this is to wash it daily or have multiple where you can switch them out, because we know that the cloth masks that most of us are wearing, they're not N95, they're not filtering, they are protecting us, but we know they can be contaminated. So washing those every day is a really good practice, and having multiple so that you have a backup. With the face shields, from what I've read, that is around the principle of making the eyes safer. So I think if you're at the distance, if you're at 6 or 8 feet, maybe that's not as necessary. But if you are in close proximity, I know in healthcare situations they're wearing them, but they're very close to their patients. I think that's really essential. But I also think you have to look at what your risk factor is, like Camilla talked about. Are you younger? Are you healthy? Are you low risk versus are you a high risk individual and need to really take all measures to protect yourself?
Thank you. Thank you. So
I think the shields are to protect healthcare workers from the high risk things, high risk medical procedures where there's going to be a lot of spray.
Yeah.
Excellent. Thanks. And good suggestion from someone about just wearing glasses, and some sunglasses can potentially help in terms of exposure. So last question, and this is a classic William and Mary woman science question. Is DNA sequencing being used to develop the vaccine or antibodies?
Definitely. You can't, that's what is being done as we speak now, is that sequence is what was actually used to create the test. So when China did the genome in December, every lab, and they made it publicly available, any lab could then develop the antigen test. That was the first step. Now, to do a vaccine, people are going back to that genome and trying to figure it out. So for everything, that sequencing is the first step. And so for a vaccine, where they're moving proteins around in that genome, trying to figure out what will make it an antigen that will have an immune response, but not cause the disease, essentially.
Yeah, it's kind of cool. They take the genome, they replicate it, and then they chop it into pieces, and then they just use segments of it to try to figure out, well, will this be a segment that will cause a great immune response and give us antibodies that are protective, and that's literally what they're doing. It's really
and
fast.
the sequencing, it's also really important to know if it's mutating. We got to know what it is to start with so we can know if it changes. So having that is really important for lab scientists.
Indeed. Well, thank you for your on-the-spot responses to some of the questions that popped up. I'm going to toss it back to Ivana now.
Thank you, Val. Thank you for being our awesome moderator. And I'm going to echo the sentiments that are appearing in the chat as I'm speaking, and thank our 3 wonderful presenters. Thank you, Dr. Camilla Buchanan. Thank you, Dr. Iyabo Basanjo. Thank you, Dr. Ashley Queen. You've done a phenomenal job.